Hello, everybody. This is Eric with FlightBridgeED, and welcome back. I wanted to do maybe a 10-minute podcast on a research study that I had just recently read, and it kind of it got me thinking about a lot of different aspects of cardiac arrest and bag valve mask management, intubation, etc. I started thinking about the AHA guidelines and the new emphasis on good quality CPR, and that is the number one resuscitative focus nowadays, that we don't want to put an advanced airway in if we have to stop CPR. And so I was reading this research paper, and it just got me thinking that I should talk about something like this. I think when we start our careers, we're so excited, and especially as paramedics, we want to get out there, we want to intubate, we want to dominate that airway and really learn how to do it effectively and efficiently. And so we want to get every airway we can. And I think through my career, I've obviously intubated many people. I've RSI'd many people. And, you take pride in that. But as you get older, you become less prideful. You maybe become a little less a little more humble. You realize that there's probably a better way. So this research paper was done actually overseas. It was done in Japan, and they looked at a lot of patients. I believe they looked at over 65,000 patients in an 8-year period that had went into cardiac arrest, and they evaluated whether survivability 1 month after the event, based on if the paramedics or the first responders use a bag valve mask for airway management or an advanced airway, whether it be intubation or a supraglottic airway. And the results were pretty profound. First I want to say is, at a hospital cardiac arrest, survivability is anywhere from 8 to 12%. Nationally, that's kind of the average. So survivability is pretty low as it is, but there was an actual 8% increase in survivability with the patients that were just given bag valve mask ventilations over intubation. So let's talk about that. Why is that? Well, remember, if you've been a clinician or a paramedic, EMT for a long time, a nurse, and you remember the old BLS guidelines way back in the 90s where we did the 5-to-1, and we just did 5 compressions to every 1 breath. If you think about how we're increasing that MAP pressure, and that's what we're trying to do. We're trying to circulate and increase the pressure in the chest to obviously circulate that blood volume. And every time we stop, we drop that MAP pressure back down. And so science has shown over the years, and we've steadily increased our compressions to ventilations, and now we're doing the 5 cycles of 2 minutes of CPR. We're doing deep compressions, full recoil, and we're doing at least 100 a minute. And they've realized that keeps a MAP pressure very high, and you have a better chance of survivability by doing that. Well, anytime we stop that for any reason, we're decreasing that MAP pressure. We're not allowing oxygen-rich blood that's left in the body to be circulated to the brain, to the tissues, to the kidneys, etc. So the whole point with maybe not doing intubation in this sense is that's where you see people stopping the compressions. Whoever the clinician is or the provider that's doing the intubations, they may need help. They may need cricoid pressure. They may need a lot of things. They may be working in a rural setting where they're working with one other provider with them, and it's very difficult to do compressions and do intubation and handle all that without stopping compressions. So I think it's really important to understand that in that setting, we kind of need to swallow our pride. We need to be doing the best thing for our patients. And, whether it be just putting in a king airway, which can be done very easily, that might be the one situation where we just skip the intubation process. We put a king airway in and we secure an airway. Or do good BLS procedures. I've stressed on other podcasts, and if you've ever heard me teach out in the real world, not over a podcast, I really stress going back to the basics. We learn good BLS procedures when we start school. That's taught that's everything. Our whole careers are based on that. You can't be a good advanced provider without good BLS procedures. And so I think there's a lot to be said about providing good bag valve mask management and placing an OPA and managing the airway that way. What's going to make the difference is the compressions. It's not anything you're going to do with the airway. We do have some oxygen stores in our body. We got quite a few. We can manage, without even being ventilated for a few minutes, and that's kind of where the AHA guidelines have progressed, to where they're not pushing the lay public out there to be doing mouth-to-mouth resuscitation. They want them to do good compressions, full recoil. The whole thought process is you have a negative pressure in your chest, and that recoil is going to actually draw some air in, and that by doing good compressions and circulating that blood around, you're going to actually be better off than maybe having a lay public that doesn't want to even get involved because they don't want to do the mouth-to-mouth resuscitation. So I think it's just something to remind us that in this setting, putting a king airway in, or a supraglottic airway where there's no stop of your compressions is probably the better option, or just going with bag valve mask ventilation, being very effective and efficient with that, and continual compressions. Don't ever stop. And obviously we need to get an IV and get some medications on board. So that's the whole emphasis of this podcast. I just wanted to remind us that survivability is our main goal. Clinical course is our main goal. We want to always do the best thing for our patients, and in this setting we probably are missing the boat, and I know I see it all the time. We need to be rethinking this. And the same goes for a trauma arrest. If you ever get on the scene of a trauma arrest and you have a patient that's succumbed already from their injuries, obviously they're very fatal injuries, and sitting there and trying to intubate that patient and doing all the things that we would do in a normal arrest situation is kind of pointless. That's where either putting a king airway in really quickly, getting that airway secured, is going to be the best option. Same thing, and then trying to fix the main causes. Not giving epinephrine, not giving those medications. That's not going to change the fact that they've bled out inside, or that they have a massive tension pneumothorax or whatever. So, we need to be doing the pericardiocentesis. We need to be doing bilateral chest decompressions and those things. And if that doesn't work, then we need to probably call that. Nothing's going to help. Definitive treatment is what they need, and if they've already succumbed to their injuries that quickly, and you've done those things that I just laid out, the patient's obviously deceased. So I just want to thank you for joining me. We're getting a lot of great feedback on Facebook. You can join us on Facebook at FlightBridgeED, and we do have a Twitter account. You can follow us at FlightBridgeED as well. Please send me your comments. You can email me at eric@flightbridgeed.com or post something on Facebook. I encourage everybody to get involved. You can go to the forums page and log in and register. There's a register button at the top right under the forums page, and just go through the steps. If you have any problems registering, please send me an email. Get involved. I've got multiple patient scenarios up there. We would love to hear your insight and see your clinical knowledge and just kind of test and see if we can learn from each other. So I again thank you so much for the support, and any ideas or feedback is welcome.